Approximately as a Bhagavatam reader, presented with the complaints of cough with difficulty in expectoration since 15 days, and spoken as whitish in color. Complaints of breathing difficulty, MMRC since 15 days. Complaints of fever.
Can you tell me what is this MMRC?
Modified release.
Okay.
4 days are this.
Okay.
Grade 1 is while walking upstairs, they will take it. Grade 2, while walking on the level 3, then grade 3 is up to 100 yards. They feel the rest they will be treated.
There are two types of classification. Predominantly respiratory cases we follow MMRC, and the cardiac cases we follow NYH. Both are almost similar.
Then no complaints of chest pain, palpitation, loss of appetite and loss of breath. Initially he was admitted in outside hospital, treated with antibiotics and nebulizations. From there they referred here for further management. Past history is a known case of multiple myeloma. He was on carfilzomib since 2023, and known case of systemic hypertension, and known case of bronchial asthma since 20.
In a case with multiple myeloma coming with breathlessness to ER, what all things you will suspect? Case of multiple coming to ER with breathlessness. She is presenting asthma, that is a different case. Suppose this case come to ER, what are your differential diagnosis? Immediate differential diagnosis. Pulmonary embolism. That is the first diagnosis. Progressive breathlessness like this, what is the common reason in multiple myeloma? It's anemia. Anemia is the most common reason for breathlessness in multiple myeloma because bone marrow production is reduced. Okay. Then suppose ribs are involved, pain because of pain, and like you told, it can be pulmonary embolism also because it's a thrombophilic condition.
Known case of bronchial asthma since 25 years. I was on regular use of inhalers. Not a known case of cold pulmonary TB or cold pneumonia. No significant family history. He was an ex-smoker, stopped 25 years ago.
What is the importance of COVID pneumonia nowadays?
Already lung condition, underlying lung condition.
COVID, what is the side effect of adverse effect of COVID infection? Fibrosis. Lung fibrosis is the most common problem in COVID. So the patient who had COVID, we should anticipate some sort of fibrosis in the lungs.
No significant travel history. On examination, the patient is pallor present, bilateral pitting edema was present, no clubbing, cyanosis and icterus. He was well built and nourished, conscious and oriented. Vitals, heart rate was 94, BP was 140/100, respiratory rate was 25, saturation was 95 in room air, temperature was afebrile. Coming to systemic examination, upper respiratory system tract examination were within normal limits. Coming to lower respiratory tract, infection, the shape of the chest were normal, trachea appears to be in midline, no intercostal introing, no accessory muscle usage. Shape of the chest was bilaterally symmetrical, no supraclavicular fullness or hollowing, no drooping of shoulder, no hyposcoliosis. Skin over the chest were normal, no dilated veins, scars or sinus. Chest movements appears to be equal on both sides. Palpation, there is no chest wall tenderness. Trachea is found to be in midline. Apex beat was palpable in left fifth intercostal space, half an inch medial to mid-clavicular line. Transverse diameter was 33 and anteroposterior diameter was 26. The chest wall expansion was about 4 cm. Percussion, the resonant note was found in all lung fields. On auscultation, there was a bilateral diffuse expirator wheeze was present. Other system examination were within normal. So we have sent for initial investigations, routine CBC and CRP. Total counts was found to be 9,000, and neutrophil was around 84%, and lymphocytes was around 5%. CRP was around 10, and Bronchial was 0.10. In order to rule out allergic cause, we have seen IgE. It was found to be 26.6. To rule out cardiac cause of breathing difficulty, we have ordered for cardiac enzymes and NT-proBNP. It were all in the normal limits. We started him on antibiotics on peptides and azithromycin, and in now of severe wheeze, we started him on steroids. So coming to asthma, asthma is a chronic airway inflammatory disease. It presents with the symptoms of cough, breathing difficulty, chest tightness and wheezing. It is mainly expiratory airflow disorder because of bronchoconstriction, increased mucus production and air wall air wall thickening. The triggers are infection, allergens, tobacco smoking, exercise, stress, aspirin, NSAIDs, and usage of beta blockers. If a patient with a chronic or recurrent respiratory symptoms, we should assess first detailed history and examination to if the history and examination are suggestive of asthma, we have to assess whether the symptoms are uncontrolled or controllable symptoms. If it is a controllable symptom, then we can ask for spirometry. If spirometry is not available, we can go for peak expiratory flow rate. Then it should be done both pre-bronchodilator and post-bronchodilator. If the value of spirometry FEV1 and FVC is more than 12% or more than 200 ml post-bronchodilator, it is significant. Or if it is a peak expiratory flow rate, if it is more than 20%, it is significant. If suppose the patient has severe uncontrolled symptoms, we cannot do spirometry initially. So for them, we can start them on inhaled corticosteroids. Then we can review after 3 months whether the symptoms are controllable or not. Criteria for asthma diagnosis is they should have a variable symptoms. The symptoms vary in frequency and intensity. It often worsen at night or more in the morning. It is often triggered by exercise, allergen, and cold air.
So variable means what? What do you mean by variable? Asthma symptoms are variable. You're right.
It is not a persistent.
It's not a persistent disease. It comes and goes.
It comes and goes.
So sometimes patient will have more symptoms. Sometimes patient will be absolutely normal. Whereas COPD, they will continuously have a symptom. It's a progressive disease, whereas asthma is intermittent, non-progressive disease.
And there should be an evidence of variable expiratory airflow limitation should be there. That is significant bronchodilator responsiveness. As we said, FE1 FVC ratio should be more than 12% or more than 200 ml from pre-bronchodilator or peak expiratory.
What is the difference between COPD and asthma here?
They will not respond to bronchodilators.
They will respond, but their response is not complete. Okay, so the response will be minimal in COPD, whereas asthma, it can be good like you told. Okay. So reversibility is a feature of asthma in PFT.
Then another point is excessive average daily variability of peak expiratory flow rate should be measured over a period of 2 weeks. If it is more than 10%, it should be taken as a significant. Then there should be a significant response to inhaled corticosteroids for a period of 4 weeks. Then there will be a positive bronchial challenge test with methacholine, hyperventilation, or mannitol, or hypertonic saline. Then there will be an excessive variation in lung function between each visits. So if a patient with a previous diagnosis of asthma, it should always be reconfirmed. If a person does not show any significant variation in expiratory airflow limitation, if the lung function is normal, then we should reassess them. Whenever the patient is having symptoms, we should repeat PFT. And after stopping bronchodilator, we have to reassess. If the patient is already taking short-acting beta agonists, it should be stopped ideally 4 hours before the procedure. In case of inhaled corticosteroids with LAMA, they are taking twice daily, it should be stopped 24 hours prior to the procedure.
That means if the patient is taking salbutamol, you have to stop for 4 hours.
4 hours.
If the patient is taking salmeterol, formoterol, you have to stop at least 1 day or at least minimum 2 hours.
2 hours.
That is because the duration of action is that much.
In case of LAMA, it should be stopped to 36 to 48 hours. There is one entity called a cough variant asthma. Their main symptom is persisting of dry cough. They will not respond to bronchodilators. For them, mainly we need to start on inhaled corticosteroids. And before starting, we should rule out other causes of persistent dry cough like GERD, whether post-nasal drip, or whether they are taking any ACE inhibitors, or vocal cord dysfunction or eosinophilic bronchitis. For assessment of symptom control, for the past 4 weeks, we should ask the daytime symptoms more than twice per week, any night waking due to asthma, SABA reliever needed more than twice a week, any activity limitation due to asthma. If nothing is present, it can be taken as a well-controlled asthma. If 1 or 2 things is present, it is partly controlled. If all the things are present, it is an uncontrolled asthma. Coming to PFT, PFT indications are to evaluate the lung disease and to assess the severity and progression, to know whether it is an obstructive pattern or restrictive pattern, and to gain to know whether they are responding to therapy.
What are the restrictive lung diseases? Common restrictive.
ILDs.
ALD is one of the diseases. Then hyperscoliosis. Pulmonary fibrosis. Okay. Then obesity. Obesity also can produce a restrictive lung disease. Severe obesity then. Neuromuscular disorders then. Scleroderma. Scleroderma is another condition. There are so many conditions which can produce restrictive lung diseases. Okay.
Contraindications for PFTs, those who are inability to perform, that is poor coordination, very young age or very old age. In case of infections like TB, pneumothorax, aneurysms, angina, recent MI, recent eye or abdominal or thoracic surgeries, hemoptysis of unknown cause, and pulmonary embolism. These are contraindications for PFT. Coming to PFT in spirometry, we have to take for first FEV1 FVC ratio. That is FEV1 and FVC ratio will be normal in normal entity and also in restrictive pattern. The next thing we have to see the forced vital capacity FVC. If FVC is normal, it can be either normal etiology or pulmonary vascular disorders. In order to differentiate these two, we have to look into DLCO. If DLCO is normal, it can be taken as a normal entity. If it is less than lower limit of normal, it is due to pulmonary vascular disorders like pulmonary hypertension or pulmonary embolism. And coming to FVC, if FEV1 FVC ratio is normal and FVC is less than 0.8, the next we have to look into lung volume, that is total lung capacity. If the total lung capacity is less than the lower limit, it is a restrictive pattern. In order to differentiate whether it is extra-parenchymal or parenchymal restrictive disease, we need to take into DLCO. If DLCO is normal, that it can be extra-parenchymal restrictive disorders like obesity, neuromuscular, or chest wall disorders. If DLCO is also lower than the normal limit, then it could be a parenchymal restrictions like ILD with or without pulmonary hypertension. Whereas if FEV1 FVC ratio is already less than 0.7, then it is an obstructive pattern. The next thing we have to rule on the forced vital capacity. The capacities will be normal in case of obstructive disorder. If it is less than FVC is less than 0.8, then next we have to look into total lung capacity. If the capacity of the lung is normal, then it is obstructive disorder. If the total lung capacity is again less than the lower limit, it may be a mixed pattern, both obstructive and restrictive. Then again we have to look into DLCO. If DLCO is normal, it could be asthma or chronic bronchitis. If DLCO is less than the normal limit, it could be emphysema. And PFT can be normal in asthma because of fluctuations of symptoms.
During period attacks only, it will show abnormality.
Coming to lung volumes, the tidal volume is the volume of air inspired or expired with each normal breath. It's ideally 500 ml in a normal adult male. Inspirator reserve volume is the amount of air that can be inspired over above the tidal volume. It could be normally 3 liters. Expiratory is the maximum extra volume of air that is expired above the tidal volume. It is normal is about 1.1 liter. Residual volume is volume of air remaining in the lungs after forceful expiration. Its normal is about 1.2 liter. Capacities, there is inspiratory capacity. Inspiratory capacity is the sum of tidal volume and the inspiratory reserve volume. It should be normally 3.5 liters. Whereas functional residual capacity is sum of expiratory reserve volume plus residual volume. It should be ideally 2.3 liters. The vital capacity is sum of the tidal volume plus inspiratory reserve volume plus expiratory reserve volume. It should be ideally 4.6 liters. And the total lung capacity is the sum of vital capacity plus residual volume. It should be around 5.8 liters. General principle of management is that it should be ideally we should add on inhaled corticosteroid. Only SABA alone should not be added in the treatment because it will worsen the allergic response, airway inflammation. So it ideally should contain both ICS plus SABA combination should be there.
ICS and SABA?
Inhaled corticosteroids and short-acting beta.
So initially, how do you suppose you get an asthma case in your clinic? You are getting a case of asthma, and you feel that it's a mild disease. How do you initiate your treatment? it's only intermittent. So according to the GINA guidelines, stepwise approach, how do you treat it?
So initially we have to start with low dose ICS and LABA combination.
Okay.
If it is in step 1, step 2, if still the symptoms are worsening, we have to go for maintenance ICS plus LABA, that is marked.
Okay. So first you start salbutamol, MDIs or DPIs, whatever it is. Then inhale corticosteroid like fluticasone, budesonide, whatever it is. Okay. Then next step is going for a long-acting drug. What long-acting drug you prefer? Formoterol. Okay. Salmeterol. What is the difference between salbutamol, salmeterol, and formoterol?
Salbutamol is short acting.
Salbutamol is a short acting. That is SABA. Okay. Short acting beta stimulant agonist. Okay. So that is what is the difference between salbutamol, salmeterol, formoterol? Basically, if somebody understands that, they can easily treat the patient.
These two are long acting.
Salbutamol is a short acting. Salmeterol is long acting. Formoterol is
Long acting.
So what is the difference between formoterol and salmeterol? What is the difference? So salmeterol is a long acting but slow acting drug. Salbutamol is fast acting drug, short acting drug. Salmeterol is long acting, slow acting. Formoterol is fast acting, long acting. So that's why nowadays you prefer or we prefer formoterol. So it acts as for both a preventive drug and rescue drug. So if you are giving salmeterol to a patient who is getting repeated attacks in grade 3, grade 4, if we are giving salmeterol, if we get an attack, you have to give another MDI like salbutamol for a acute rescue drug. But if you are giving salmeterol, then the same drug can be used for both. That's why nowadays we use salmeterol with fluticasone or budesonide combination. Okay, then what else? What are the other drugs you give along with formoterol with fluticasone, formoterol with budesonide? That is the third stage onwards, third step onwards you'll be using. What is LAMA? What is it? Tiotropium or ipratropium. What is the difference between ipratropium and tiotropium? Ipratropium is short, tiotropium is long acting. Okay, then next step is what? Along with the third or fourth step, you can start some other drug. What is it? Steroids. Steroids we are giving inhaled steroids, but you can give oral steroids in acute condition. Is there a difference between oral steroids, IV steroids? In emergency, we are giving IV drug, oral drug. Is there a difference? Yes, sir. Huh? So suppose I am having asthma, I don't want to take IV. So can I take oral steroid? Both are same. Whether you give IV steroid, oral steroid, bioavailability is same. So there is no point in giving waiting for IV injections. You can suppose you have oral tablets, you can give same effect. Only thing is when the patient cannot take oral drugs like severe asthma, you will not be able to give. In that case, you give IV. Okay. Then what is the difference between inhaled corticosteroid and IV corticosteroid? Is it same? So patient is having acute severe asthma. You are able to start nebulization of fluticasone or budesonide. Should we give IV steroid or oral steroid? What is the difference between nebulized steroid and oral or IV steroid? Oral and IV are same, but nebulized steroid is not same. It is lesser bioavailability. It takes longer period. It takes nearly 2 weeks to get a peak action of a inhaled steroid. That's why immediately you are giving either oral or IV. And along with that, you are starting your nebulized steroids. Once the patient is discharged, you are putting an inhaled corticosteroid. Okay. Then any other added oral drugs you are giving along with this LABA and inhaled corticosteroids? Delphiline is not there in the guideline now. It is removed. What else? What is montelukast, saffron-lukast? Huh?
Interleukin receptor, antihistamine.
It is not antihistamine.
Interleukin receptor.
Interleukin as leukotriene. Leukotriene modifiers. Okay, that should be started. Okay, how do you start it? Short, few days or long days?
Long.
It should be given anything, any days more, any day more than 15 days. Okay, it should not be a short action. It's not a short duration prescription at all. You have to give 3 months, 4 months like that. Then what else you can use? What is the newer treatment in asthma? IG mediated drug can be tried. If the IG levels are very high, then that can be tried. Okay, anything else? It was done in your department, but now we are not doing it. Thermoplasty. What is it? It was done here, but nowadays we are not using it. It has not gained much popularity. It's not a new treatment, it's an old treatment. But these IG mediated drugs are a new treatment. It is used in many patients. Anything else? What is the role of magnesium in asthma? It is not there in GINA guidelines. It is not at all in mainline guideline. What is the action of magnesium? It's a bronchodilator. Long-term use can prevent repeated hospitalization. That's all. We don't know what is the exact action of magnesium in asthma, but it prevents repeated hospitalization. Role of what is it? Vaccines, pneumovac and H influenza. So both should be given for all the patients. Okay, anything else you want to tell? So PFT is a very important. This 6 minutes walk test. What is it? So it is 6 minutes walk test.
We have to assess the previous saturation after walking for 6 minutes. We have to reassess the saturation.
Not only saturation, you look for heart rate, BP, saturation, and everything. There is a very good tool in your OPD to find out whether the patient is improving or deteriorating. Okay, so we have to advise. We can check for 6 minutes walk test. Incentives parameters. What is that? What is incentives parameters? We are using in ICUs all patients we are giving. It increases the lung volume. Okay, lung function may not increase. The volume will increase. The dead spaces will be utilized. So that slowly patient will be trained to use his dead spaces. Volume of the lung will increase. Lung function may not increase. Lung function will increase only with your drugs. Okay. So that also we should advise the patient. So lung physiotherapy, this incentives parametry, 6 minutes walk test, all these things are there in your like OPD management. Okay, anything else? Medicine. Okay, thanks.